WAP initiative to celebrate the World Down Syndrome Day. Today we have the dignitaries like Dr. Professor Sumantra Sarkar, Dr. Sujoy Ghosh, Dr. Suchandra Mukherjee, and none other than Dr. Somir Hassan Dalwai. To start with, we have kept a theme. Today we have it is the end of the stereotype. Professor Sumantra Sarkar. এরকম কেন শুনছি আবার? So the theme of today's discussion will be the end of the stereotypes in managing Down syndrome babies. So we are very happy that our president of WAP, Professor Ashok Datta sir, has joined. So I'll request Professor Ashok Datta sir to tell a few words, and then I will introduce the speaker one by one. Over to you, sir. Unmute. Ashok, unmute.
Thank you, Swapun, for your introduction. Good afternoon, all learned speakers and all the audiences who are here. This is a special day, Down Syndrome Celebration Day. I will not talk too much, only a few words I'd like to say. What is the need of this celebration day? Why it is 21st March every year. It started from 2012, and thinking is that we usually know the Down syndrome is trisomy 21, though there may be other causes of there. But whatever it may be, the 21 is trisomy 21 is present case of Down syndrome. So 21 and 3, they are related together. That's why it is 21st March. So everyone can remember it. And second important thing is that why we should celebrate it. To relieve the stigma which is associated with Down syndrome. Lots of stigma are there. We usually, our society is still not habituated to accept the patients with some problems. This is the most important stigma, social stigma. Though not all Down syndromes are say not capable of doing some things, there are lots of proof that some people with Down syndrome are doing excellent jobs in relation to their beautiful arts activity, in relation to their specific or special ability to do something. We have learned speakers are there here, and they will give us the information in relation to that, and everyone will get some knowledge part of that. They should have some rights which are not done in our country till now, which is the Disability Act 2016 which passed. It is not applicable to all regions of our society. This is also, this syndrome celebration is a drive also. This syndrome celebration is also a drive to memorize these events, this day, and this is why we should. There are lots of other points are there. I request Swapun to continue the sessions, and with thanks, I'm ending here.
Thank you, Professor Datta, for your kind words. Now we'll move on to our first session. It will be the challenges in establishing Down syndrome specialty clinic. It will be delivered by Professor Sumantra Sarkar, who is the head of the Department of Pediatrics in Diamond Harbour Medical College. So over to you, Dr. Sarkar.
Thank you and good afternoon. And this is a wonderful opportunity here from the West Bengal Academy of Pediatrics to celebrate the Down Syndrome Day, World Down Syndrome Day. So I am here to deliver the presentation on the challenges to develop Down Syndrome clinic. Is my screen visible?
Yes.
Yes.
Visible. Nicely visible.
Put it into a slide mode. Yeah, perfect.
Yeah.
Sumanto, you may continue.
Yes. Challenges to establish a Down syndrome specialty clinic. So, at the onset, we must remember on the special day, one taskbar is coming. Yeah, thank you. So, at the outset, we remember on the special day, the English physician, John Langdon Down, who explained the phenotype of children with common features noticeable from other children with a mental retardation. My screen is not moving.
No. We can see it. We can see
Screen
it.
is not moving.
ডবল ক্লিক করুন, যে কোনো একটা এর উপরে ডবল ক্লিক করুন।
Yes. So this is the fellow who has on whose name this Down syndrome has been named. So Down syndrome, the most frequent chromosomal abnormality, is caused by trisomy of human chromosome 21. It's the most common chromosomal anomaly among live births and frequent genetic form of intellectual disability. The incidence of Down syndrome is observed at approximately 1 in every 700 live births. Now, why do we need a Down syndrome specialty clinic? Firstly, the individuals with Down syndrome need special care that we know. The proper counseling for the parents on a common platform is the second need. Thirdly, they are at higher risk of certain other diseases. I am coming one by one and discuss. And the statistical data showing increased number of children with Down syndrome. And lastly, need to establish our own database and continue our research. Firstly, the individuals with Down syndrome need special care. They need early intervention and educational therapy. The early intervention refers to a range of specialized programs and resources that professionals provide to very young children with Down syndrome and their families. The treatment therapies include the physical therapy, the speech language therapy, occupational therapy, emotional and behavioral therapies, parental guidance, and some of them may require assistive devices also. And the Down syndrome children are at higher risk for certain other diseases. They have hearing loss up to 75% of patients, obstructive sleep apnea, congenital heart defects, more than 50% of patients, ear infections, eye diseases like cataracts up to 60%, eye diseases requiring glasses in 50%. They have early onset Alzheimer's in their 40s. Many of them have autism. They can present with intestinal atresia very early in life. They have hip dislocation, thyroid disease, very common. They have iron deficiency anemia. Some of them, 1% patient may have leukemia in infancy or early childhood. They can born with Hirschsprung disease. So people with Down syndrome are 50% more likely to have other diseases than the general population. There is one database that shows that one study prevalence of structural birth defect among the infants with Down syndrome. The published data in birth defect, they have shown that the 12.7 per 10,000 live births prevalence was shown. And among these children, 75% had at least one reported co-occurring birth defect diagnostic code. Among the 6,210 cases identified by active programs, 66% had a cardiovascular defect, with septal defects being the most common. So many of the patients have this kind of birth defect like congenital heart diseases. And the data and statistics on Down syndrome showing an increase over the years. Each year, about 6,000 babies are born with Down syndrome. The database there in the CDC government data. And between 1979 to 2003, the number of babies with Down syndrome increased about 30%. And if you go into the data, that is a study published in American Journal of Medical Genetics, they have shown the number of people living with the DS has steadily increased from 1950 until 2010 in these 9 US states. Actually, this kind of database are not available in India. All studies are done in the foreign countries. So my point of view is that the persons with Down syndrome are increasing day by day. And if you go into the life expectancy of people with Down syndrome, it will be found that the life expectancy was 10 years in the year 1960 and is changed to 47 years in 2007. The infants with Down syndrome who also had a congenital heart defects were 5 times more likely to die in their first year of life compared to normal infants. But with the advent of recent therapeutic services for congenital heart defects, there are decrease in the death from congenital heart defects. One data from 1979 to 2003 had shown there is a decrease death from 8.5% to 5%, a decrease about 41%. Certainly after 2003, with the advent of more advanced therapeutics, the death rate further declined. So come to the present situation in India. There is no official DS registry, no authentic data on the incidence of prevalence. Some isolated data generated from sporadic studies in the different parts of India. And one published data from ET Health World was suggested that Down is the most common chromosomal anomaly globally, and it affects approximately 30,000 to 35,000 children born in India every year. It could be a data, but the authenticity of data, I don't know, but it is a data published everywhere. So now coming to the challenges in setting up a Down syndrome clinic. There is a need of purposeful awareness and motivation among the healthcare professionals. That is the most challenging part. We need the positive and futuristic awareness among the parents and family. There is a difficulty in getting the administrative approval we need for the multidisciplinary setup. And lastly, but not the least, need for the financial support. So first, we have to change our mindset. Many times, what we see, when we see the patients, we just write congenital heart defects in a case of Down syndrome. We always consider Down syndrome as a case or a patient. We never think that they are also persons with all the human emotions and having immense potentials to develop a purposeful person in the society. So first, we need to change our mindset. That is the most difficult challenge among the healthcare professionals. So for that, we need a continuous source of motivation. And the person beside us, Dr. Sujoy Ghosh, is Associate Professor of Geology in the Down syndrome unit. So we get a constant motivation from Dr. Ghosh and their institute and their fellow colleagues. And obviously, our patients are our best motivator always. This was the first Down syndrome case was present in our Down syndrome clinic. And I was the lone warrior at that time in 2021. But the ball started rolling on 22nd December 2022 with the support of the state government. We organized one CME on Down syndrome on that day with the help of our institute. The wonderful participation was there, and there was an enthusiastic leadership at the institutional level by our principal, Professor Utpal Kumar Da. And without his enthusiasm or leadership quality and inspiration, it would not be possible to develop this Down syndrome clinic in our institution. And there's also cooperation and inspiration from the Central Kolkata Welfare Association for Persons with Down syndrome. They also inspired us. So another inspiring contribution and assistance from Dr. Sanchita Das, who was Commander-in-Chief in starting this Down syndrome clinic. And we got the energetic and enthusiastic participation from our juniors also, our students. So our ball started rolling. This was the team on that day. And in the first Chetran Medical College to get separate unit for treatment of special kids, there was a publication in the next day. And we started with our specialty clinic. So one by one step by one step, we started running. But initially, we have started our outdoor and indoor. But the struggle continues. It was an arduous journey of hope. In the initial days of struggles, we had only the indoor service, OPD service, and counseling, but not a formative one. I have already told the challenges. The most important challenge is now to develop a multidisciplinary setup. We need to wait until our DIC start functioning from 1st September 2023. It was once again an initiative from the state government and with the help of our higher authorities, our principal sir, our MSDP sir, we have started our DIC. Initially, there was a struggle. We thought it would be started at 1st September 2023, but somehow it was not started. It started from 1st September, and then we could organize our Down syndrome clinic in a proper way. We have started getting a room there in the OPD. Down syndrome specialty clinic was started once weekly, and we got enthusiastic juniors to start with. And with them, we made a standard operative procedure. What we made, we have collected the patients from various ways. The newborn clinically diagnosed as SNCU, or clinically diagnosed patient at general OPD, or any patient admitted to indoor with complications, or we can get a referral from other health facilities. Particularly, our Diamond Harbour Hospital is a referring hospital for the many other hospitals from South Bengal, particularly Kagdi, Mograhat, Canning. So many patients are being referred to our specialty clinic, and also we are getting referral from the private clinics. So all these patients now we are taking them in our specialty clinic every Monday, and where we can do the registration, detailed clinical assessment, including developmental assessment, initial parental counseling, then necessary investigations. We send them for normal blood counts and other like TSH estimations, karyotyping, collect the blood for karyotyping and send to our genetic unit run by Dr. Sanchita Das. And also we can send this for the research purpose to Dr. Sujay Ghosh and their unit. And we treat them for the common illnesses. All these are done by the support of the state government of West Bengal at free of cost. So this handholding was important to develop this kind of specialty clinic in our government hospital. So after all these procedures, we usually refer the patient to our DIC for further management. Some of the patients may require admission for inpatient care. Some specialty referral required for endocrine or cardiological evaluation. Unfortunately, now we don't have any cardiological unit, and we are struggling with the echocardiography, the lack of echocardiography support. So we have to send this patient to outside, also with the financial support by government. So these patients are being regularly followed up our designated special clinic. So with this, this is our DIC unit, where the developmental assessment done under the nodal ship of Dr. Piyashi Mondol, who is doing a laborious job with other people. And the dental assessment is there. We have a proper dental setup in the DIC. And there is an ophthalmological evaluation, and the special educator has joined, and the skill training has been done for the Down syndrome children. And this is a physical skill training unit where the occupational therapy as well as the physical therapy are done. We don't have occupational therapists yet, but physiotherapists are now doing excellent job in our DIC. Some patients are having autism spectrum disorder. They are also being treated in our unit. So this is our team DIC Diamond Harbour under the leadership of Dr. Piyashi Mondol. And obviously, we don't forget our manager, Dr. Subra Prakash Ghosh, and his team. And the team consisting of the psychologist, the special educator, the lab technician, the ophthalmologist, optometrist. So it's a wonderful job that being done on daily basis in our institute. So we have linked up our specialty clinic and give support to our Down syndrome patients, rather Down syndrome individuals. But the problem still continues because we need continued financial support. The 0.5 was there. Average medical cost, for the Down syndrome babies, 12 times higher for children with Down syndrome compared to the normal children. And Down syndrome child with a heart defect at healthcare cost 5 times higher in the first year of life. Fortunately enough, the Down syndrome children with the heart defects are being operated free of cost under the Shastro Sati scheme in the West Bengal government. We can link up with the RBSK and Shastro Sati scheme. But still, many children are waiting for the corrective surgery for their congenital heart defects. So this is a area we have to develop much more. So with that, miles to go before we sleep. Thank you for all for patient hearing. Thank you.
Thank you, Sumanto, for your excellent presentation as well as your involvement in setting up the first DEC in Diamond Harbour. I think it is the first center in the government also. Yesterday, Howrah Academy of Pediatrics has also done a fantastic program in Saksham. It is being done by the Howrah Municipal Corporation, and all the subspecialties have been taken care of. Everything has been done under the same floor. So this is fantastic. But do you just give any guideline of doing the periodic checkups like the heart, the thyroid scan, or the pelvic ultrasound, or the dental checkup yearly, 6 monthly, 2 yearly, and up to how many years? So can you please enlighten us?
Actually, what we have done until now, since September 2023, we have enrolled around 30 patients of Down syndrome, new enrollment we have already. And then those patients are undergone this kind of evaluation like congenital heart diseases. So I have already told that presently we don't have the facility for echocardiography. Previously we had, but now we are struggling with. But with the help of the Rogi Kalyan Samiti's fund, we are sending the patient for echocardiography under government setup. And the biochemical setup like TSH estimation, all are done in a hospital. Dental care are done. Initial detection of the problem and followed by the regular checkup done by the dental specialist in the DEIC. Those are there. So all over we have started very recently, and I think in near future we will develop much more with the help of the other facilities and other super specialties, because we don't have that much facilities now at our institute. But hope it will be done in future.
I'm really hopeful that under your guidance, the DEC in Diamond Harbour will definitely come up with the flying colors. And
thank you, but it is not
a new and all the Down
team game. It's absolutely team work, and it is under the guidance and leadership of our institutional head, Professor Utpal Kumar Da, and also the state support. That hand-holding is required. So we need a recommendation. We need a particular guideline to develop. What we have done a SOP in a local basis, but we have to work in a very bigger way. And what we do right now is also we are doing some researches with the consent from the parents. We are taking the blood sample for the karyotype as well as from genetic studies. So in future, we have plan of certain researches also, and with the collaboration with Dr. Sujoy Ghosh and his team, we hope that it will be done very well.
Thank you. All the very best. And now I have got our...
Can I comment?
Yes, sir. Please.
Sumanta, I must thank your excellent initiative. This is very much required. And one thing, you have a tie-up with the collaboration with ophthalmology, because many of the Down syndrome suffer from a lot of ophthalmic problem.
Yes, we have optometrists in the DIC, and also we have the Department of Ophthalmology in the Diamond Harbour Government Medical College. The department is also doing a wonderful job. They are also providing some good care for the patients.
Achha, are you making any data of their disease pattern, their outcome, and all these things?
Yes, we are doing it. We have started only for a few months, and then I hope that in near future we can develop the good database with all the heart defects and all those diseases. So already we had some publications in the international journals with Dr. Sujoy Ghosh and his team. Because I was working on Down syndrome since 2011 when I was at SSKM. I must not forget the contribution of Professor Supratim Datta, the HOD of SSKM Hospital. And then in the pediatric department, we started the research actually with the help of the Dr. Sujoy Ghosh and his team. So already we have had a good database, not only from the Diamond Harbour, but also from Diamond Harbour and also from SSKM. So total Down syndrome patients are much more than what we have in our Diamond Harbour setup. So already we have a good database, and we have a lot many publications on this data also.
Okay, thank you very much. Thank you.
Thank you, Subhashis.
Thank you.
So what I am doing right now, actually, I am giving proxy on behalf of Professor Mihir Sarkar. Now I can see him. So Mihir, please take the charge and invite Dr. Sujoy Ghosh.
Yeah, thank you, Swapanda. Actually, there's another program was going on. Sorry for the late entry. I was stuck on there. So excellent presentation by Sumantroda. And now we're moving to the next presentation by Dr. Sujoy Ghosh. Dr. Sujoy Ghosh has many accolades in his crown. But to make it short, Dr. Sujoy Ghosh is presently working as Associate Professor in Cytogenetics and Genomic Research Unit of Department of Zoology, University of Kolkata. And he is now currently the chair of Indian chapter of T20 Research Society, which is which has spread all throughout the globe. And his research mainly related to the genetics, the environmental risk factor, and the congenital heart disease in Down syndrome. And Dr. Sujoy Ghosh will be speaking on the insight into the causes of the health issue among the children with Down syndrome. Yeah, and Sumantroda has already mentioned his name several times. So this is the main, lot of work and the genetics has been done in the part of India from Dr. Sujoy Ghosh and his team.
So this is the adverse effect.
Yes, Dr. Sujoy Ghosh, you can just share your screen and start.
Dr. Ghosh, please share your PPT.
Is my screen visible to all?
No, no, no.
No, not you.
Difficult.
There's a share screen option. This is the green button, arrow and the up arrow.
Yeah. I'm calling my student because they are more acquainted with it. এইটা একটু share করে দাও তো। So here is the Zoom. এটা তো দেখাচ্ছে না এখানে।
কোন জিনিসটা দেখাবেন?
Share screen option আছে না, একটা share
Just beside
Yeah.
chat, there will be a one green icon over there. There is a share screen, and you just open your PPT and make it minimized. Then you can get it there. First, open your presentation and then minimize it.
If you have difficulty, you can send it to me. I can share from this side and you can go ahead.
এইখানটা দেখো। এইটা না খুব সমস্যা জানো তো, এই অ্যাপেলে এটা প্রবলেম। Actually, it is from Apple. That's why.
Oh, that's why, huh?
Yes. Okay.
Yeah.
Now it's coming. Yes,
Yes,
we can see.
perfect.
Yeah. So, first of all, I should acknowledge and extend my sincere gratitude to this organization, West Bengal Association of Academy of Pediatrics, and Dr. Mihish Sarkar and Dr. Sumantra Sarkar for inviting me and giving me opportunity to share some of the work that we have been doing for the long time with the Down syndrome. Basically, I am not a clinician. I am a basic researcher, scientist, and geneticist, and started my research on Down syndrome since the year 2001. So a long time I devoted my career in the Down syndrome research. So let's start with this, the insight into cause of health issues among the children with Down syndrome. So at first, I should remember the slogan of Down Syndrome Day this year, that is Stop the Stereotype. So the focus of my lecture is that to understand that all the Down syndrome are not identical. So this is the basis of our study. So trisomy 21 have several co-occurring conditions. Nearly 80 different co-occurring conditions are found in the trisomy 21. And I think Dr. Sumantra Sarkar has narrated all these things very elaborately. And there are a lot of variations in the occurrence of all these co-occurring conditions between the Down syndrome individual and the normal individual. That is, almost all individuals with Down syndrome, they have high degree of dementia, and the age of 40s or late 40s in their age, they develop the symptoms of Alzheimer's disease. We called it as the early onset of Alzheimer's disease. They have 10 times more risk to develop autism, epilepsy, up to 400 times more risk of pediatric hematological proliferative disorder, different kinds of leukemia. They have 25% more frequency of autoimmune disorder and obstructive sleep apnea, pulmonary hypertension. But on the other hand, they have some less probability of co-occurring condition like coronary artery disease, at least 5 times less in Down syndrome individual, and over 10 times less of solid malignancy. So being a geneticist, we started looking into the chromosome 21 and their gene content. Near about 500 DNA base pair located in this small chromosome. It is an acrocentric chromosome of the human body. And near about 250 different genes are there. Those genes are involved in the various activities of our physiology. So our goal and challenges of Down syndrome research is to increase the quality of life with those with having Down syndrome and to decrease the health effect of extra dose of chromosome 21. And what are the challenges? Not a change in the single gene. Actually, Down syndrome involve the gene dosage imbalances of nearly 250 genes that are located on the chromosome 21. And all these genes have several cross-talking with the genes from the other part of the genome. And that's why these dysregulation not only restricted to the genes which are located on the chromosome 21, rather they are actually influencing the other genes from the other part of the genome. So let's start with congenital heart defects. We have a lot of working with the congenital heart defect. And among the congenital heart defect, this is the kind of distributions. AVSD, nearly 50 to 60% of all individuals with Down syndrome, they have congenital heart defect. And among all kind of congenital heart defect, AVSD is the most frequent, followed by VSD, ASD, PDA, and TOF. So among these, we started working with AVSD, atrioventricular septal defect, and being a clinician, all of you are familiar with this kind of problems in your patient group. So AVSD not only actually influencing the heart, but it actually influencing the different kinds of the activities and incidents in the life. And that may lead to hospitalization, that may cause cognitive impairment, that may affect the activity level of individual, and that may influences the weight control mechanism of the individual with Down syndrome. So what we started at the beginning, we started looking into the responsible genes related to the AVSD. So it was not easy. So we have one tool, that is genome-wide association study, that is GWAS. So using GWAS, first we try to identify which loci beyond the chromosome 21 are responsible for the AVSD and have close association with AVSD. So we have taken Down syndrome sample with AVSD about 210 and Down syndrome sample without AVSD 242. And with this, we conducted GWAS study, that is genome-wide association study, to find out which are the responsible loci associated with the occurrence of AVSD among the individual with Down syndrome. Followed by, we did whole exome sequencing to look deep into the genetic architecture of those identified loci. That is, if there are any kind of mutation, polymorphism, changes in the base sequences in the DNA that may influences the AVSD in the individual with Down syndrome. So we got, there are some genes, I am going to this result, there are some genes which are actually exhibited strong association with AVSD, and among those genes 19 mutations we have identified among 8 different genes across the genome. That is interesting. These genes are not only from the chromosome 21, these genes are also from the other part of the genome, and all these mutations are absent in the individual who don't have AVSD. That is the interest, our interest to look into more into the genetics. So what are those genes? These are the genes, that is COL6A1, COL6A2, CRELD1, FBLN2, FRZB, and GATA5. Among those, COL6A1 and COL6A2 are from chromosome 21, but other genes, these are not for chromosome 21, they are from the other part of the genome. So what we hypothesized, we hypothesized that when these two genes, that is COL6A1 and COL6A2, are triplicated in the trisomy 21 condition, this extra dose of proteins, they influences chromosome 2, chromosome 3, chromosome 20, and other component genes which are responsible for the cardiogenesis and regulation of cardiac activity. So when there is extra dose of these proteins, they are actually imperil the balances of other proteins which are not replicated. So that is why there is a complication, and this complication manifested in the different way among the individual with Down syndrome in the different groups. So next steps, what we did, we translated our result, that is these mutations, into the mouse model. We have several interesting Down syndrome mouse model. These mouse models are very effective to look into the different genetic conditions in Down syndrome. And we just inserted those genes into the mouse to look whether the mouse exhibits similar kind of congenital heart defect or not. Interestingly, when we put this mutant form, in the disomic mice, we found there is embryonic lethal. That means when both the copy of the genes are missing, then disomic mice also exhibited acute congenital heart defect, and these are embryonic lethal. But when we put these mutations in heterozygous condition, that is one copy of mutant gene, but other copy of wild type normal gene, into the disomic mice, there is no congenital heart defect. That is natural because these mutated, that is minus copy of genes, is balanced by the plus copy of good copy of genes. And that is why these mice exhibited absolutely normal heart development when in disomic condition. But when the similar situation develops into the trisomic mice, when there is triplications of the chromosome 21, the same heterozygosity lead to 33% occurrence of congenital heart defect. That is why some of the individual with Down syndrome, they exhibit congenital heart defect, but some of the individual with Down syndrome do not exhibit any kind of congenital heart defect. From this, we tried to develop one hypothetical model. This model is like that. You have triplicated chromosome 21 genes, And these triplicated chromosome 21 genes, they are contributing genes for the cardiac development. At the same time, you have several genes from the other part of the genome where chromosome number is normal too. But when these triplicated genes undergo complicated interactions with these disomic genes from the other part of the genome, a spectrum of the different impairment develops. And that spectrum of the different impairment we have designated here by putting different shades of green color. There are 4 conditions could be possible. One is chromosome 21 genes with wild type copy, chromosome 21 genes in polymorphic or mutant copy, and alternatively non-chromosome 21 genes, that is genes from the other part of the genome having wild type copy, and genes from the other part of the genome with mutant copy. The first quadrant is a combination with chromosome 21 gene with wild type copy and non-chromosome 21 gene with wild type copy. This is an ideal condition, and probably this is a very, very hypothetical condition, because even we, those who are actually normal in our heart structure and function, probably carry some mutation also and polymorphism also. But as we have normal disomic genetic background, our genetic system try to nullify the mutational effect, and that is why we actually have absolutely normal heart condition. But when these human chromosome 21 specific gene having polymorphic or mutant variety with non-chromosome 21 disomic gene with polymorphic mutant variety, this combination going to absolutely lethality and acute congenital heart defect. All these interaction influences in the different way the Notch signaling pathway, NF-ATC pathway, VEGF pathway, and Sonic-Hedgehog pathway. All these signaling pathway are responsible for the cardiogenesis in the embryo, and that ultimately manifests in the different degree of congenital heart defect, maybe AVSD, maybe VSD, maybe tetralogy of Fallot, or may no defect at all. That is why all the Down syndrome, if we try to equalize, they are not equal. They have several degree of differences, or we can say it simply, they have different subtypes of the Down syndrome. With the same notion, we are trying to look into the genetics of the Alzheimer's disease in the Down syndrome. As I told earlier, the Down syndrome individual, they develop Alzheimer's disease, but not all the Down syndrome individual develop Alzheimer's disease. Even in our study cohort, Sumantroda knows it very well that some adult individual having their age 50 or 52 or 53, they're absolutely healthy. They don't have any sign and symptoms of Alzheimer's disease. But in some other groups, the 42 years old boy or 45 years old girl, they develop certain degree of the dementia. So by age 40, most of the people with Down syndrome had this type of senile plaque in their brain, along with other protein deposits, that is, you know that better than me, that is tau triangle, which call problem with the low brain cell function and increased risk of developing Alzheimer's disease. Estimates suggest that 50% or more of the people with Down syndrome will develop dementia due to Alzheimer's disease as they age. Again, there are 50% are there who don't have any kind of Alzheimer's disease or dementia. And very interestingly, girls have more tendency to develop dementia than the boys. So this is basically the genetics of Alzheimer's disease development in the Down syndrome. In nutshell, chromosome 21 carries APP. You know that very well, amyloid precursor protein. As this is triplicated in Down syndrome, there is excess amyloid A beta accumulations in the cerebral amyloid angiopathy, which is responsible for, and there are dysregulation of the immune function, cholinergic and adrenergic degeneration, and several oxidative stress and premature aging. But again, we have found that APP is not solely responsible for development of the Alzheimer or dementia in Down syndrome. There are several other mutations other genes which are responsible. That is why among the individual with Down syndrome, we have several spectrum of different dementia and intellectual disability. So this is a diagram showing the normal brain and with Down syndrome brain. And if you compare the PET scan of the Down syndrome brain and Alzheimer autosomal dominant typical Alzheimer patient's brain, you can see this kind of the similarity. This Down syndrome, it's a brain structure of 33 years old lady, and this is a brain structure of 65 years old lady, but they have similarity in their brain functioning or dysfunctioning. So looking into the genetics, other than APP, there are several panels of genes that exhibit overexpression under the influence of overexpression of APP, and all these genes contribute significantly in Alzheimer development in the Down syndrome, as well as neuroinflammations and oxidative stress associated with Down syndrome. Taking example, the most interesting gene of this panel is DYRK1, 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 RANKAN1, they are responsible for the neurofibrillary tangle formation. SOD1, RANKAN1, both they are responsible for the excessive oxidative stress and mitochondrial dysfunction. SYNJ1 and RANKAN1, they actually induces defect in the exocytotic event and endosomal dysfunction, one of the significant demarcations of Alzheimer patient. CSTB, this gene, when overexpressed in the Down syndrome individual, causes lysosomal dysfunction in the neurons, and S100B, that is responsible for the neuroinflammation. So our research target is to minimize this gene dose effect among the individual with Down syndrome to make their life more comfortable and easygoing. So as you know that it's very difficult to do research with the clinical sample, particularly when we are looking into the neuroscience. So we have to design several preclinical research model. So these model organisms are mouse, rat, zebrafish, fly, and Caenorhabditis elegans. And you can see using this color, we are trying to give a comparative overview how the genomes of these individuals are similar. Mouse and chimpanzee, they bear both the chromosome 21, which are absolutely identical. But when we come down to the rat and mouse, the chromosome 21 genes of human, they remain scattered in the chromosome 11 and chromosome 20 for the rat, and chromosome 10, chromosome 16, and chromosome 17 for the mouse. In case of zebrafish, this genomic fragmentation is much more compared to human. Chromosome 1, 6, chromosome 10, and 15, they carries several pieces of chromosome 21 for human, and in also fly and Caenorhabditis elegans. But all these models are very much instrumental for initiate any kind of incisive research or for the Down syndrome. So what we actually do, we start with a clinical sample as Dr. Sumantra Sarkar recruited at their clinic. And after that, we collect their genome, or rather biological sample, and look into the genome. After looking into the genome, we try to replicate all the situations in either of these models. And from these models, we get some incisive idea regarding the disease pathology and molecular biology. Then we try to design certain drug, and again we start with this model organism. We apply those drug onto the model organism and see the effect. And if the results will come with a very positive note, they try to go for about the disease pathology of Down syndrome. You need to look into the genomics first, then transcriptomics, that is total RNA profile, then proteomics and metabolomics as well. These multitudes of coordinated omics approach could help us to get an overall idea of the to be personalized or precision medicine design for the individual with Down syndrome. As I stated every time, that all the individuals with Down syndrome are not identical. They have different body need. They have different interventional need. That is why if we have the genetic, proteomics, and metabolomic blueprint of individual with Down syndrome, the eminent clinicians, could design their management strategy accordingly. So now we are looking for more sophisticated and advanced tool for the research, and these are iPSC. We successfully collected the body cell of Down syndrome individual, particularly the skin cell, and then we reprogrammed the skin cell to produce certain iPSC, that is stem cells. And from these stem cells, we just want to recreate the definite organ called organoid onto the laboratory petri dish. So these organoid and these iPSC, these are very instrumental. These are very beneficial for our research, because we don't need any model organism. We are taking a little amount of the cell from the trisomy body, that is human body, that is clinical sample, and transform these cells into what kind of the cell we want. We can convert it into the neuronal cells, we can convert it into the hematopoietic cells, we can convert it into the muscles or any kind of the cells. And from these cells, we can recreate a small part of the brain, blood tissue, muscle or skin onto the petri dish in laboratory. And then we can use any drug to get its effect onto the organ. So these are some beautiful instrument for us for the further research. And very interestingly, probably you are familiar with this, that is gene editing and chromosome silencing. These are some very advanced technique. We are trying to apply this technique for correcting the gene dose imbalances in the individual with Down syndrome. But unfortunately, we have not applied all these techniques on the clinical sample yet. We applied all this onto the mouse model and Drosophila model, and we got some very good promising result.
Dr.
So,
Ghosh, sorry to interrupt you. We have 3-4 minutes more, okay?
Okay. So I am also just completing my lecture. So here is include, this is this site, it's a website for NIH, National Institute of Health. You all people could access this. This include is dedicated site for National Institute of Health USA for individual with Down syndrome. Various kind of informational resources are available at this moment at these sites, and you people can register as a clinician, as a family member, as a researcher, and get access to the all resources or databases present in this include sites. And this DS Connect is also a global registry, Down syndrome registry. Any family from any nation could access it and register himself or herself into this registry. So we have this international collaborative research team across the globes from USA, UK, and currently I am representing the Asia here. And we have Trisomy 21 Research Society, that is a researcher network across the globe dedicated into the Down syndrome research. Clinicians, basic researcher, young researchers, and advocator, all members are working together to make a new light into the life of Down syndrome individuals. So this is our international conference. This year we have international conference in June at Rome. And this is my lab, my research team. It's a pretty large team at University of Calcutta. And these are some of the important publications. And in all this research publication, Dr. Sumantra Sarkar is our collaborator. Unless Dr. Sumantra Sarkar, we could not move forward with Down syndrome research, at least in India. So with these few words, we often meet with the families. We provide free advocacy and charitable support for those families, and have a nice day. Thank you.
Thank you, Dr. Sujoy Ghosh, for very lucid presentation. As though this is a topic is a bit tough for us as a clinician, but you have made it much easier. Any question from Swaponda?
Yeah. Dr. Sujay Ghosh, I am giving you an invitation to please step in Bihar, MGM Medical College, a postgraduate institute. I will give you ample of cases. In every week, I can give you 30 cases.
Oh,
So please
great.
step in sometime.
Actually,
This is my invitation.
Actually, from this platform, using this platform, I'm just appealing all of you clinicians, please come forward, because unless you hold our hand, we could not move forward. We could not carry forward this research for the benefit of the people. So we want that more and more clinicians should be in our network and will support our research. Thank you for this invitation.
So thank you, Dr. Sujay Ghosh. Now moving to what's the next session? I think Suchandra madam is there. Madam, can you hear me? Yeah. So madam is the one heading the one of the most developed developmental clinic, DIC, in our state, that is IPGMR hospital. Madam is by profession is neonatologist, but doing madam and her team is doing a fantastic work on the from the newborns to and from the all children with special abilities. They're doing fantastic work and the vast experience, and they have multidisciplinary unit. So over to you, madam, to start your presentation.
Thank you very much, Miki, and I'm thankful to Indian Academy of Pediatrics and Dr. Sumantra Sarkar and Professor Sujay Ghosh. It was actually my learning. We have started long back.
Louder, ma'am. Come
Bit
closer
louder,
and be
bit
louder.
louder. Yeah.
So am I audible now?
No.
You are audible, but your voice
Is low.
So my screen is visible?
Yes. Go to slideshow, slide slow mode. It is visible, but go to slideshow mode.
Madam, go closer to the laptop.
It's actually a desktop.
Okay.
So we just start with the last line of Professor Sujay Ghosh that all Down syndrome children are not alike. So every day we are just struggling in our own unit, like Sumantra was telling, to give a comprehensive care to the Down syndrome children in a busy OPD. Because DIC is meant for all developmental delay children, maybe neurovascular, other syndromic cases, and definitely being the most common genetic disorder among the syndromic babies, number of Down syndrome children are the highest. So from newborn, we are now following up till 6 years, maybe more also sometimes. So this is a huge cohort of Down syndrome children, and always we think as a team member of our DIC, we have to provide a comprehensive care from the neonatal age group till adulthood. So this is the biggest challenge of all the clinicians. So Down syndrome is a Down's baby and child, but a baby with a Down syndrome. So she is not a Down's baby. Second, I want to tell that Down syndrome is not a disease. Every day as a clinician, we have to counsel the parents. So what is that? What will be the prognosis? And is it a disease? So Down syndrome is not a disease or not a handicap, but better word preferably be the condition. It is a genetic condition. So Professor Sujay Ghosh has very lucidly deliberated in his talk that why there some Down syndrome children are suffering from cardiovascular disorder and some Down children in the adult age group having Alzheimer's, and all Down syndrome children are not having those disorders. So actually when we are counseling the parents, this knowledge in the back of our mind will help us to tell the probable outcome of Down syndrome children in future. So thank you, Dr. Sujay Ghosh, for enlightening us from the genetic background. So cervical has improved with, and now the Down syndrome baby are surviving till 6 decades. Because of the comorbidity, treatment of the comorbidities are advanced, especially the heart diseases. Now the treatment of heart disease are available at free of cost through this government, this Shishu Sati scheme. And non-complicated heart disease, the Down syndrome children are having very good prognosis in adult life. Studies have shown that children with Down syndrome may be offered a rich environmental stimulation, then significantly it will improve the IQ score. So that's the role of the DIC. So when we are talking about the multidisciplinary or multi-system services to the Down syndrome children, the background is it is an enriching environment where the parents are coming and all the therapists in the DIC, they are acting in a transdisciplinary mode with the parents so that the parents can learn and they will offer the best possible treatment at home also. So that is the crux of the success of this multidisciplinary follow-up in DIC. So what are the things related to the Down syndrome follow-up? Is there any need of multidisciplinary approach? Definitely yes. What are the components? Components, the pediatrician in the nodal center will be the pediatrician or neonatologist, whatever. Then
Ma'am, slide is not moving. Slide is not moving.
I'm not moving the slide. Is it okay, Sumantra? It's moving from my end.
We can see the first slide only.
Okay. So what are the, it is a neat multidisciplinary approach, definitely yes. What are the components? The pediatrician, the special educator, the psychologist, the physiotherapist, audiologist and the optometrist. They are the main pillar of a DIC for Down syndrome children, because whenever we are talking to the parents of Down syndrome children, we just give them an idea that they may have this cognitive development from delay, maybe mild to profound. But if we can screen this eye, the vision and the hearing issues from a very early infancy, definitely the outcome will be improved in future. So all the Down syndrome have a potential to have at least mild to moderate delay, not severe. The severe developmental delay, sorry, can be ameliorated with the sensory screening in very early age group. Is it moving now?
Not yet. It is a first slide, madam. Stop share and reshare. Stop share and then reshare.
That's what we are doing. Stop share. Then I will share for you. Is it changing now? Or the first slide?
Go to slide share mode, slideshow mode.
No, the slide is changing now. Is it changing?
No, not changing,
No,
not
no.
changing. It is changing now. It's changed. Yeah.
Make it in a slideshow.
Ma'am, there is an icon just below your panel, just beside 64%. That icon has to be clicked.
This is the share. It is already been shared. Ensure. Stop sharing. 64. There is a slideshow. Is it okay?
No, it is not yet
Yes,
shared.
it's the second slide now. I think it will move now. Ma'am, please move on to the second slide, then we can make out whether it's moving or not.
No, this slide is moving from my end.
Yes, now we are on the second slide.
This is the second slide, this one the third. So is it changing?
No.
So I just stop share. এখানে share button ছিল সেটা করতে। Mihir, I think you can start the next speaker's topic, maybe.
Indudi, Dr. Shomir has joined, Dr. Shomir Dalwai sir. Then we can go ahead with his presentation. After that, madam can do.
He won't be available right now, I think. So the CIAP meeting is still going on, I think. They have a Zoom meet till 4:10. It started, but they are running late. So we have to continue with ma'am. Only then we can have him, I think. Still, I'll try to call him.
Okay, okay.
Dr. Dalwai is there.
No, but I think
He's
he
logged
is.
in. He has just
I
logged.
think Ashok sir has joined also from the same link. That's why I have shared the link to Ashok sir. That's why.
Yeah.
Mihir,
Yes, sir. Yes, sir.
অথচ আপনার নামটা চেঞ্জ করে নিন। ওই উপরে দেখুন তিনটে ছোট্ট ফুটকি আছে, ওই তিনটে পটে যান, গিয়ে ওখানে নেমটাকে চেঞ্জ করে নিন। আর আমরা বুঝতে পারছি না যে সমীর দালওয়াই ঢুকে যায়। বাস
এটা কি ভালোভাবে বুঝতে পারলাম না,
হয়ে গেছে।
আমি করে দিলাম স্যার সোমনাথ।
আচ্ছা আচ্ছা, ঠিক আছে।
তো সোমনাথ দা, ডক্টর মুখার্জির থেকে স্লাইডটা নিয়ে নিন না, দিয়ে আপনি মিহির নিয়ে নাও না। মিহির,
যা খুশি।
এটা ইজি হয়ে যাবে।
ম্যাডাম স্লাইডটা একটু পাঠিয়ে দিতে পারবেন আমাকে, তাহলে আমি সোমনাথ দাকে দিয়ে দিচ্ছি স্যার করবেন।
ম্যাডাম স্লাইডটা এতে পাঠিয়ে দিন আমাদের মিহিরকে।
মেল আইডিটা দিতে হবে, একটু মিহির করে দাও, টেক্সট করে দিলে আমি পাঠিয়ে দিচ্ছি হোয়াটসঅ্যাপে।
টেক্সট করে দিচ্ছি আপনাকে।
সোমনাথ দেখো ওটা পাস করে দিলেই হয়ে যাবে।
ইমেল আইডি আমি সেন্ড করে দিয়েছি ম্যাডাম।
মিহিরটা আমাকে হোয়াটসঅ্যাপে পাঠিয়ে দেবেন।
Hello.
হ্যাঁ, পাঠিয়ে দিচ্ছি।
Can you join now? So you join now because the third speaker, she's having some problem with. Samir has joined, so I think Dr.
Yes,
Samir.
so you can introduce Dr. Shomir and start. Because I am on road at present. Sorry for that.
Okay, so welcome Dr. Samir to this webinar on Down Syndrome Day, and Dr. Samir needs no introduction. So he's in a hurry also, so I'll just give over to Dr. Samir. You can please begin with the deliberation.
Namaskar, pranam, good afternoon to all my seniors from WAP, from all the state, city and the district branches, all my respected, I can see at least Dr. Swapan Da here, and my friend Dr. Indu, and Dr. Sujay Ghosh, Dr. Sumantra ji, Dr. Ashok Datta sir, Dr. Samir, Dr. Subhashish, Dr. Mihir Sarkar, Dr. Bhattacharya, Dr. Das, Amita ma'am, so many of my friends. So thank you so much. Thanks Induji for this program on behalf of the chapter. I only wish to make a few points, and that's why I've not made a PowerPoint presentation, because the matter is very, very important and it has to go to our hearts. All of us are very, very keen to work for children with Down syndrome. There is no two things about it. There are two parts of working with children with Down syndrome. One is the purely medical part. Everything is medical, but purely medical, I mean in terms of cardiovascular, I mean in terms of gastrointestinal, I mean in terms of nutrition, hemato-oncology. So these parts all of you have covered already today. Again, in the evening, we have a webinar from the chapter where these parts only will be focused on. But the other part is the developmental part. So I'm just going to talk about the role of the pediatrician in the developmental part. We must understand most importantly that development is basically a sequence. It is a step-by-step achievement of certain skills and functions that the child has. And the nature of these functions is such that each function is dependent on the earlier milestone. Each later milestone is dependent on the earlier milestone. If the child is not able to sit, the child will never be able to stand. If the child is not able to stand, he will never be able to walk. If she is never able to walk, she will never be able to run. The same holds true for social communication development. What we as pediatricians have to understand is just like we will monitor the fever. If the child has high-grade fever, comes to 105, you may make a diagnosis of enteric fever. You may start an antibiotic. The fever won't come to 99 next morning. There is no immediate improvement. But you are looking at 105, next day 104, then 103, 102, 100. Similarly, the clinical functions, the malaise, the irritability, the illness, all is getting better step by step by step. The same thing happens in development. Unfortunately, somebody has convinced us that development is some ajib hocus pocus. Only some so-called para-professional experts know how to do development. Pediatrician का कोई लेना देना है नहीं development से. इससे बड़ा झूठ कोई हो ही नहीं सकता. और ये करने से we are abdicating our responsibility. अपनी जिम्मेदारी हम accept नहीं कर रहे हैं. We are willing to give antibiotics, we are willing to do everything else, but we are not willing to look at development. Why? Because we are looking at the disorder. And the reason for this is, in the exam, if there is a Down syndrome case, who gets a gold medal? Swapanda, you are the professor giving gold medals, doing examination all the time, conducting
neurological, if you get neurological case, it becomes easier.
Sorry?
Easier to come. If you get the neurological cases, passing exam becomes easier.
Correct. So when you keep a child of Down syndrome and ask the student, what is his case? The fellow will say he has mongoloid slant, he has low set ears, he has this, that. If he says 10 things also, you will pass him. If he says 15 things, you will give him distinction. If he says 20 things, you will give him gold medal.
Yes.
The same student now goes in private practice and starts seeing patients. A parent of a child with Down syndrome walks in. वो बोलता है अरे इसको ये प्रॉब्लम है, ये प्रॉब्लम है, ये प्रॉब्लम है, ये प्रॉब्लम है, 20 problems. Swapan, the professor Swapan Ray gave me gold medal for this. When he tells this to the father starts crying, mother starts crying. They don't want to know the abnormalities. Professor Ray wants to know. Because professor wants to know whether you know the abnormalities, whether you know the disease, whether you know the disorder. Parent doesn't want to know that. He will get tremendously frustrated, dejected and sad. What he wants to know is what is good in my child. What examiner wants to know in the exam is what is wrong in the child. But what the parent wants to know is what is good in my child. So it is easy to say, oh, this child is not walking. Correct. That doesn't solve the problem. You need to know, is this child standing? If he is not standing, is this child sitting? If he is not sitting, is he rolling over? Oh, he is rolling over, but he is not yet sitting. Forget about walking and running for now. For now. Start focusing on rolling over and how you will work from rolling over to sitting, one milestone at a time. Do whatever it takes to get the child from rolling over to sitting. You do whatever comes to your mind. Tell the parent that. Now, IIP has done the nurturing care ECD workshop. Shopanda is here, Ashok, the sir is here. These booklets were made. And in these booklets, you have been told what to do for normal development of the child. Tell the mother what to do from rolling over to sitting. In addition, if you have a DIC, send to a DIC. If you have a therapist, send to a therapist. Do all that, but you are the primary person, because you know that the main thing to do is not treat Down syndrome. There is no medicine that takes away that extra chromosome, but you also know that you need to make the child who's rolling over sit. If this much you tell the parent कि अभी तुम इतना ही करो और ये करके मेरे पास वापस आओ, उसके लिए मैं बताता हूँ क्या करना है, ये करो और थेरेपी करो, ये करो, लेकिन मेरे पास 1 महीना में वापस आओ और मुझे बताओ, is now your child sitting? If they come back after a month, say, sir, child is sitting, but with support, very good. Work for 15 days more on sitting till the child becomes sitting without support. Or 15 days, 1 month, come back. Google is asking me if I'm speaking another language. So I'm speaking. So come back after 15 days, 21 days, 31 days, but come back and tell me, now the child is sitting without support. What is your next goal? Not high jump, not javelin throw, like Neeraj Chopra. The next step is standing with support. Again, go to the IIP book, which is the ECD book. Sir can send you all a copy. Even now, sir, you just make it digitalized and please request Swapandra sir to send it to everybody. Indu madam is very, very hardworking. You do it. Secretary of WAP, do it. Vinay bhai, do it. In that it is said what to do to make the child from sitting to standing. Teach the mother. Tell your receptionist or your assistant to teach the mother. Then send to a therapist. Tell the therapist, I want this child that you work on sitting to standing in the next one. Don't give me hi-fi jargon. मेरे को उसमें नहीं जाने का है. You tell me, and you also tell me, therapist, what can I tell the mother to make the child stand? Once the child, again, go home, come back after 2 months, do all this, but come back to me. I am this child's pediatrician. This is my child, not anybody else's outsourced child. Come back, child is now standing with support. Some more time standing without support. Automatically, AUTOMATICALLY, automatically the child will start taking steps. Automatically the child will walk with support. Keep working on that, the child will walk without support. The same holds true for communication and social behavior, but the mistake is we think either the child will speak or the child will not speak. That is like saying either your child will run or not run. We just realize what makes a child walk and run. Sitting, standing, walking, and then running. So similarly, for speech, what we have described is a New Horizons social behavior and communication sequence. First step after birth is human engagement. Is the child engaging with the mother, with the father, with the Masi, with the Pishima, with the Masima? If he is engaging human engagement, is he behaving socially with them? Fortunately, children with Down syndrome are best at that. The more time he spends with mummy, dadi, nani, Pishima, Masima, Bua, Mami is more important than spending time with Dr. Dalwai or therapist or you. That time is most important. So make sure you tell them, take the child to Masi's house, Pishi's house, the grandmother's house, neighbor's house, Samaj, Pados, neighborhood, and get the child to understand how different people behave. Dr. Chopin behaves like this, Dr. Ashok Dutta behaves like this. I should know what to do with both of them. This is social learning. What to do with whom is social learning. This is what the child cannot learn from you or me or from therapy, can only learn from Pishima and Masima. Because Pishima is different, Masima is different. Koi khadus hai, koi relaxed hai. You cannot teach the child. No therapist in the world can teach this to child. Not even the mother and father. Only Pishima and Masima can teach. Ki, this is how you have to behave with me. This is how you have to behave with me. This is social learning. After doing that, gradually the child will start learning non-verbal communication. So use a lot of non-verbal communication and less verbal communication. First, if the child is not walking, no point teaching running. You will break the bones. First, focus on walking. So first focus on human engagement, social behavior, kahan pe kya karna hai, and non-verbal communication. And gradually start using one word. If the child has good human engagement, good social understanding, how to behave with masi, chachi, kaki, bua, politically, diplomatically, then the child will also pick up non-verbal. 90% of your work is done. After that is the time that the child will start picking up speech, and tell the parents speak less, speak clearly, and speak slowly. बेटा इधर आओ, ये उठाओ, बेटा इसको करो, ये रखो, सॉक्स पहनेगा बेटा, अरे मोबाइल देखे रहा है, खाना खाएगा, चॉकलेट चाहिए, बिस्किट. This is how parents speak. This is how parents speak to the child. The child who can't understand one or two words is facing a barrage of non-stop cacophony. It is called overstimulation syndrome. The child is getting hyper because of so much of kyaw, 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 kyaw. Like how the wife does to the husband or the husband does to the wife if they meet after a long time. Child gets irritated. Tell the parents, come बात करो, आहिस्ता बात करो, स्पष्ट बात करो, clearly बात करो, और बात करते करते action use करो. Because the child can pick up the actions and understand the word. And then the child will start picking up words. After he's picking words, then he can go to the school. So this is very important. And the only person in India who can do this is the pediatrician, not the development pediatrician, not the therapist. You are the owner of this process. You can involve a therapist, you can involve a psychologist, you can involve everybody else, but you are responsible for making them do what you want with this child, so that the child achieves the next milestone, then the next milestone, and then next. And from down, the child will go up, 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 and up, or more ahead than you and me also. So this is just a few things that I wanted to plead with my pediatrician brothers and sisters. And this is my request to all of you. Thank you so much. Again, all of you are so kind and loving all the time. So I'm grateful to all of you. Sorry if I'm mistaking somebody's name. I my mistake, but thank you so much.
Thank you, Samir bhai. It's an excellent speech without any presentation, but that comes from your heart, and actually we can communicate with each other. It's a fantastic listening to you so many times, but it's always new.
Dr. Samir, can I ask you one question?
Yes, bhai.
Actually, you told this social learning in a extended family, but now very few of the families extended. Most of the families are actually nuclear, and you will not get any Masima, Pisima in that family nearby. So that is the one thing. And another thing, how far they can go to this normal schooling and all these things for this Down syndrome? Your experience, please.
To go to a normal school, it doesn't matter whether you are Downs or not Downs. It matters whether whatever they need for junior KG, you already have achieved it or not. In junior KG, they need a child who can live, who is toilet trained, or who can indicate toilet, and who can speak, and most importantly, stay away from the mother and father for 3 to 4 hours. That can be possible only with a pishi mummy and a masi mummy, or a chachi, or a neighbor, or somebody else. And that is why we have to tell the parent this, that more than normal school or special school, more than developmental pediatrician or Dr. Dalwai or Dr. Swashish, or more than therapist or speech therapist, you need the neighborhood. 4 years back, we were complaining in our country, there are no speech therapists, there are no occupational therapists, there are no physiotherapists. Abhi kahan se aa gaya? When there is a demand, there is a supply. But what I'm worried is, what are they doing? Is it really helping the child? Because they are doing artificial. I also said, I can't teach the child what the child will learn with Pishima and Masima. I can't teach. Even the mother can't teach, father can't teach. So we have to tell parents that you need this. And one of the reasons children are doing badly, because you are not giving them this. At least it is not more difficult than importing anti-malignancy drugs or some costly medicines. Parents are not aware about this. And sir, let me tell you, not you, but I have many experience of pediatricians. The moment they see a child with Down, they will say do therapies. So the mother has a chachi, masi, bua nearby, but she shifts to a city where there are therapists or Dr. Dalwai and starts doing therapies their whole day. Even if she has a Pishima inside her house, she does not take the child to the Pishima because the child is busy doing therapists. So my humble submission is, The world has flipped over the wrong side today. We have flipped the wrong side of the coin. Let us begin by telling the parents, "Ki, this is needed. This is needed. It cannot be substituted." Let us see what they're able to do. In Mumbai, what we do, there are all these big towers. So we take 5-6 mothers together of all kinds of children and tell them, look, each of you look after the child for 3 hours every evening. Mothers and fathers. So one father or mother may take off once in a fortnight. And in that evening, all the children come to his house. And then he has to entertain them, play with them, make some games, blah, 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 maybe even make some food. The next evening, all of these gang will go to the other father's house or the other mother's house, and so on and so forth. So in Bombay, तो कोई किसी का है ही नहीं सगा, relative तो है ही नहीं. Neighbors also don't want to talk to each other, but you have to make it happen. That is my suggestion to you, sir.
Thank you, Dr. Samir. Thank you.
Thank you. Thank you, Bhai. Now we can move on to our next speaker, Dr. Suchandra
Thank you.
Mukherjee. Thank you, Samir Bhai.
Okay.
Shobanda, will you excuse me, please? Can I
Yeah,
carry
please.
on, please?
Yeah.
Will you excuse me?
Yeah.
Thank you.
Please, please.
Thank you.
Thank you, Dr. Samir. Thank you.
Thank you, Mirda. Thank you so much. Thank you. Ashok Datta, sir, thank you so much.
So, Suchandra ma'am, Somnatha, are you sharing the screen? Somnatha, screen share করছেন?
হ্যাঁ
স্লাইড শো মোডে যাইনি, তাহলে একটু স্লাইড শো করে
করছি।
হ্যাঁ, ম্যাডাম দেখতে পাচ্ছেন? থ্যাংক ইউ ডক্টর সমীর।
মিহির,
হ্যাঁ,
সব কালকে চিঠি করে সব দিয়ে দিবি, দিয়ে পুরো আমাদের ওই ফাইলটা এইটাকে আপনি করতে হবে, বুঝলি? চিঠিগুলো এখানে এর মধ্যে আছে তো?
বেরোতে হচ্ছে গো।
বলুন।
হচ্ছে একটু
বলুন। বলুন।
বেরোতে হচ্ছে একটু।
ঠিক আছে। ঠিক আছে।
Next slide, please. Next.
দেখা যাচ্ছে স্লাইড সমট হয়েছে?
হয়েছে।
হয়েছে।
ম্যাডাম স্টার্ট করুন।
Dr. Dalwar, our experience is the same with the Down syndrome children. Very good strength in this visual imitation and socialization. So always the family members trying to engage those children by utilizing this extraordinary socialization and emotional developmental capabilities. So whenever we are getting as a pediatrician a Down syndrome baby, we are just starting with the medical past first, because all these neurological and this movement, these are to the say to 4 and 5 months, it is like all these typical children, because there is not so much difference in the neurological examination except the hypotonia, and this hypotonia also varies from the one child to the another of Down syndrome. Within group there is a variation. So always we try to think the baby as a whole, the part of what is the strength of the baby, and accordingly we have to counsel the parents, because now in 2024 the survival of the Down syndrome, if the comorbidities are well taken care of, then it is around 60 years.
আমাকে একটু বলবেন যখন নেক্সট স্লাইডে যেতে হবে।
চেঞ্জ করে দিন, you can change the slides.
জাস্ট নেক্সট বলবেন।
Next. So especially our postgraduate students and all, because in SSKM hospital we had some unfortunate incidences of abandoning Down syndrome baby, and that baby had a salvageable heart lesion. So this is very unfortunate, and the fault is not lying with the parents, but it is with us, because we are the pediatrician. When we are doing the prenatal counseling or preconception counseling, this Down syndrome outcome, we are telling to the parents that baby will have more profound developmental delay, this baby will have heart diseases, this baby will have Alzheimer, or the early onset this hematological malignancy. But the scenario is not like that. So it's our duty to train the students so that they can also try to counsel the parents with a positive attitude. So Down syndrome baby is a baby with a very good potential in this social, emotional, developmental. So we can utilize those domains to cover up the less strong or weaker domains. So first of all, we start with this clinical part. So definitely the history, because the type of Down syndrome, whether it is a trisomy or translocation, is very important, because when we will counsel the parents for next pregnancy, so if it is trisomy or it is translocation, definitely in case of translocation, the recurrence rate is much, much higher. Pre and postnatal karyotyping, feeding difficulties we have to address within first 1 or 2 months. We are doing the hearing test along with hearing test, because this I have taken from the Singapore, it's their guideline. We have their own guideline, and there is a national guidelines, this RPSK Down syndrome module, there is a guideline. Anybody can use, but according to our setup, we can just modify, because here we have added the screening of eyes. It is very important within first 1 or 2 months, especially in the first visit in the neurodevelopment clinic, to look for congenital cataract with a red reflex test. So if we miss this congenital cataract in the first or second visit, definitely the baby will have some problem later. Again, there is a universal screening for all those disorders like thyroid, and this XPD, this prevalence is higher, but thyroid is very important, because Down syndrome baby is very likely to develop hypothyroid, not only the congenital hypothyroid, but in the later childhood also. So regular and frequent screening is essential. Next slide. Next slide. So now 4 to 12 months, again this growth is very important, but growth should be plotted in a Down syndrome specific growth chart, not in the IFP or our WHO growth chart. So it is freely available and downloadable in the internet. So we can download and keep in our OPD or in the private chamber to use for plotting growth of a Down syndrome child. Now 1 to 5 years, again this eye and this hearing also, because there is sometimes this effusion in the middle ear that may cause damage to the ongoing hearing function. So this is very important from the clinician point of view. Next slide. And 1 to 5 years, again we have to see for the sleep pattern, because sometimes due to obesity, the baby often suffer from the sleep apnea and the dislocation and the subluxability of the atlantoaxial joint. We also keep in mind while we are doing the clinical examination of a Down syndrome from 1 to 5 years of age group. So again, multidisciplinary approach. Dr. Dalwai so very nicely he has elaborated the role of the family members here, because all the family members can act as a therapist, but much better therapist than these professional therapists can offer to a baby. Next slide, sir. So if we are talking about the cognitive development, the range is from mild to profound. Profound where? Because if the baby suffer from a hearing or the vision problem, definitely a mild to moderate developmental delay may be present as profound delay. So our role as a clinician is to screen for the sensory function first, and as early as in early infancy. Speech and language difficulties are more pronounced. Relative strengths are in visual spatial processing in this population. So usually the parents and the therapists, they are utilizing the vision, this visual imitation, and the social and emotional this strength for the weaker section like this cognition and sometimes also in the motor. Next please, sir. Next slide. They have difficulties with motor skill, and not only the motor milestone, but there are some problem in the motor planning and the praxis in the adult Down syndrome. So they are showing extreme motor delay in the infancy or in the toddler age group, but when they are grown up adults, they will have problem to plan the voluntary motor function, and they will have problem in the fine motor development also. Next slide. Next slide, sir. So the neurology and psychiatry part, being a pediatrician, we are very interested to see whether our Down syndrome baby is having any problem in the brain. So seizures are very common. It's around 5 to 6% of patients with Down syndrome, and 40% of these patients present in infancy. So this Down syndrome baby presents with seizure within 1 year of life. And the most common type of seizure and infantile spasm. But fortunate enough, the infantile spasm, the outcome is better in Down syndrome baby than other causes like metabolic or some structural anomalies of brain. And if we look for the psychiatric and childhood psychological disorder, then the most common is the anxiety, obsessive compulsive disorder, depression, and sleep related issues. This is very important because these child often suffer from sleep apnea. Autism spectrum disorder, we have already discussed. It is present around 16% of cases, and some overactivity and hyperactivity disorder also is not very uncommon in Down syndrome babies. So they respond to therapy and they have some reciprocal skills. And when we are talking about the impulsivity and attention, so these here, the psychologist and the special educator will, in DIC, they will see the baby, assess along with the parents for counseling and home-based planning for home-based intervention. Next slide, sir. So this is the MRI of a Down syndrome baby. So there is some changes, even if the baby is not having seizure, even if the baby, the person with Down syndrome is not going to develop Alzheimer at the age of 40 years, but still, if we do a volumetric MRI analysis, there is some changes in the volume, especially in the pons, especially in the frontal cortex, hippocampi, and in the cerebellum. So sometimes the baby present with developmental delay, and they are, some children are having much delay than the other. So in case the baby is having cerebellar atrophy, Vermeer hypoplasia, in that case, the baby will have more hypotonia and more developmental delay, and sometimes it takes time to keep the baby in a sitting or independent standing position than a baby with Down syndrome who do not have cerebellar and Vermeer hypoplasia. Next slide. So optometry, this is very important in DIC or in the other setup in a district hospital or medical college hospital where optometrists are available, because screening and surveillance of the common vision related disorder is very common in Down syndrome, and most common is the strabismus. You all know, because the presence of epicanthic folds and the slanting of eyes, often Down syndrome babies are they're looking like the baby is having strabismus, but actually the baby is not having squint. But still, Down syndrome baby are suffer strabismus, this congenital cataract and developing cataract, blockade of the nasolacrimal duct. Refractive error is very common, sometimes glaucoma and nystagmus. We have seen many cases with Down syndrome having jerky horizontal movement, that is nystagmus. So these are fairly common in Down syndrome children. So we have to screen starting from very early age group, from newborn for congenital cataract, and sequentially for refractive error, presence of cataract, developing glaucoma and strabismus. Next. This is the red reflex, this orange glow from the vitreous and blood vessels. So if this orange glow is not present, that means the baby either suffering from congenital cataract if it is in newborn period, or the baby is developing some opacity in the media, including developing cataract in case of Down syndrome. So this is very important to screen with a direct ophthalmoscope to see whether the red reflex is normal or not. It can be done by the pediatrician. Next slide. So this is actually the Hirschberg test. So we see the reflection from this cornea. If it ordinary torch, when it is reflecting back from the cornea of a baby with a Down syndrome. Just see this upper one is symmetrical, but the lower, the B, it's the deviated. So that means the baby is having strabismus. So it is pathological, it is not related to slanting eyes or the epicanthic folds. So this baby needs urgent treatment. It may be due to amblyopia, it may be due to refractive error. Unless the baby is corrected with glasses, the baby will develop poor vision, and definitely cognitive outcome will not be favorable, like in compared to the baby with Down syndrome who do not have strabismus. Next slide, sir. So this is retinoscopy for refractive error, and this is a vision testing. So vision testing for a very small child is not very easy because they cannot follow the octotype, that is the Stenel chart. So there is a special kind of chart, Teller Acuities chart, and it is a preferential looking method. When the baby is interested to look the gratings, the stripes, the size of stripes, so there is a calculation what is the visual acuity of the child with Down syndrome. So it can be done from 3 months, less than 3 months onwards. And it can be done for older children also when the child is not cooperating or the child is preverbal. Next slide. So audiology is again important because the Down syndrome baby often suffer from issues in the ear because of some unique anatomical problem. So universal hearing screening is mandatory, and we have to refer to the ENT surgeon after the early infancy if the baby's ear canal is not seen or the baby is having problem in hearing. Tympanometry may be necessary if the tympanic membrane is poorly visualized. So otitis media, conductive deafness is much more common in Down syndrome babies than sensorineural, and otitis media in common we are telling this glue ear because there is effusion in the middle ear, and that may cause transient or permanent deafness. So it should be screened as early as possible. Next slide. So this is the tympanometry being done in a small 2 months old baby. And if the ear canal is not visible, then you have to see whether the tympanometry is normal or not. If it is not normal or the duct is stenosed, then you have to keep open the nares. If it is nose is congested, then there will be higher chances of infection in the middle ear, and definitely that may cause pain, and recurrent infection may cause permanent deafness. Next slide. So this is a tympanogram, same child. If the baby is showing problem, then you have to treat for that. Next. So there is a inherent pathology due to anatomical problem in Down syndrome babies, like the narrow and more horizontal eustachian tubes, sometimes the stenotic outer ear canal, large adenoids. Within around 3 years of age, 2 to 3 years of age, we are getting babies with sleep problem. The baby is having adenoids. So all the pediatrician should anticipate that Down syndrome baby may have large adenoid. So you have to treat first, otherwise the baby have some problem in hearing. So sometimes they are having small nasopharynx and results in reduced airway size due to soft tissue collapse and sleep apnea. So this is the temporal lobe CT, and here you can see the stenosed ear canal in comparison to the baby who do not have Down syndrome. Next. So ENT consultation is very important for sleep apnea. Now, how we can suspect the baby is having sleep apnea? Because the baby will be going hypoxic in the night during sleep, and if it is continuous, then all sorts of problems like this chronic pulmonary hypertension and this ongoing cognition problem in cognition will come up. So snoring, sleep disturbances, daytime sleepiness, nocturnal sweating, mouth breathing, chronic rhinorrhea, difficulty in swallowing, upper respiratory infection. Sometimes the baby, the child may complain of headache and persistent or secondary enuresis. Sometimes this is associated with sleep disorder and cyanosis. So if it is present, so we have to take help from our ENT surgeon for the cause of sleep apnea. Next. Atlantoaxial instability is very important because when the physiotherapists start doing physiotherapy, they should be aware that there is a condition that the baby may have instability of the atlantoaxial joint, and a cervical spine X-ray can be done. If the child is showing abnormal head posture, deterioration of the manipulative skill, that is fine motor, deterioration of gait, and frequent history of frequent falls, which could not be explained from his hypotonia, increased fatigability on walking if these signs are present, and no alternative is found to explain the symptoms, then one should go for a cervical spine X-ray. But if the child is asymptomatic, there will be no gain if we can do a X-ray without symptom. Next. So early intervention, we are not going into the detail because Dr. Dalwai, he is the expert on that, and he is very nicely, he has told all these, how we can enhance the potential of the Down syndrome by involving all the family members as a therapist. Next. So what is the scientific background? Because during intervention, one should focus in a particular domain, and that is the stronger domain of the Down syndrome child. Then only the parents can work better with the child, and this improvement will be faster. So working from this framework, intervention will choose strength as strongly as weakness. Most of the time, therapists are very keen to see the weaknesses of a child, but it should be reversed. We have to look for the strength of the child. Then you can have a better prognosis with the children. Delaying initiation of treatment, maybe with the parents also or with the pediatrician. Mere eye contact or talking to the baby can change a huge inside the baby's brain, especially in the Down syndrome baby. So these are very small intervention. We can start as early as in the first month of life. So they are very good potential for visual tracking. So we can use that. The social emotional development. So interactive talking, the social smile, and this interaction with the parents is very important for a Down syndrome baby in less than 3 months. Children may show better outcome when parents are trained directly by the practitioner. So they have to be told, so these area we have to explore. That is the role of our DIC professionals. Next. So motor evaluation goal will be independent transfer and mobility and general strengthening due to the low muscle tone and the joint hypermobility. Next slide. For occupational therapy, we have to increase the functional independence for the fine motor work. We have to make the baby ready for going to school or some fine motor work like writing, drawing, and household job also. And definitely the self-care activities for daily living like dressing, feeding, toileting, grooming, and all. Next. Speech therapy, again, it is a vital role. But before that, you have to treat the hearing part first and then the therapy. To introduce variety of textured food, this is also very important just to enhance the power of swallowing, and that will decrease the refluxes and problem in swallowing and the intermittent desaturation while feeding. Next. So Down syndrome is the most common chromosomal anomaly. The children with Down syndrome, it is a rich environment that can change the prognosis of a baby. Multidisciplinary intervention is essential. Always we tell involve the parents along with the therapist for better and faster improvement. So this is the activities in DIC. So every Down syndrome baby is unique. So for Down syndrome day, we have to pledge specially to teach the younger generations and our students that Down syndrome baby may have, and they have the right to grow with a full potential. Before that, as a clinician, we have to treat the treatable conditions first, especially the hypothyroid, the heart disorder, hearing, vision. Sometimes they are suffering from recurrent infection due to problem in the immunity, and that has also have a genetic background. So here the pediatrician roles in immense, not as a clinician, but as a teacher also, so that our babies with Down syndrome may grow with the full potential as a responsible citizen of the country. Thank you very much.
Somnath, you can stop sharing. thank you, madam, for nice presentation and highlighting the multidisciplinary approach, the what you are doing at your center, and it is very important to know all the pediatricians, the facilities available, and how to do with the patients with the Down syndrome, when to refer them, and how to, as a role of as a pediatricians, the primary care physicians for these children, what are our roles. Thank you again. And Swapanda, are you there? Indudi,
Yeah.
then you can conclude it, Swapanda.
So thank you, Professor Sumanto Sarkar, Professor Sujay Ghosh, and Professor Suchandra Mukherjee for your presentation. And
you.
I have already thanked Dr. Samir Dalwar for his nice talk, not presentation, for his nice talk. And I have already given open invitation to Professor Sujay Ghosh to please step in our hospital. Sumanto was there once for taking the exam, and he will get ample of the cases. My only interest is that if you can do the genetic testing of those children in these poor families of Bihar, it will be very helpful for all of us, because you are doing the research, and this research will might have been enhanced to some extent. So, and it is the WBAP initiative under the guidance of Professor Mihir Sarkar and the coordinator, Dr. Indu Surana. I thank you all, and let's call it a day.